Okay, let's jump into this deep dive. Imagine this. See an animal, and they really look like they need to pee.
Yeah, maybe they're straining, looking uncomfortable.
Exactly. And you might even feel their bladder. It feels full, but, well, nothing's happening. Or maybe just a few drips. And here's the kicker. The vet checks, and there's no obvious physical blockage. No stone, no tumor, nothing solid in the way.
Right. And that's where this whole topic of functional urinary retention comes in.
It's functional urinary retention. Okay.
Yeah, we're looking at the materials you sent, especially that detailed clinical guide, and it defines it as basically the animal can't empty its bladder properly.
But not because something's physically blocking the tube.
Precisely. It's because the body's own control system, the nerves and muscles coordinating things, isn't working right.
So it's more like a software problem than a hardware problem? A biological glitch.
That's a great way to think about it, yeah. And the sources point out this makes it really tricky to diagnose.
Because it looks like a blockage.
Exactly. So vets often have to rule out all the physical possibilities first. It's what they call a diagnosis of exclusion.
Makes sense. You check for the obvious culprits before looking for the subtle ones.
Right. So our mission here in this deep dive is to use these sources to help you understand what this functional retention actually is.
Okay.
Why does that normal system break down? How do vets figure it out if there's no blockage? And importantly, what can be done?
Sounds good. We'll cover the normal process, what goes wrong, how it's spotted, and how it's managed, sticking strictly to these sources.
Perfect.
All right, so let's start with how it should work. The sources call it a symphony of urination or micturition. Tell us about the normal process.
Well, the guide describes it as a really complex, coordinated act. It involves the bladder muscle itself and the sphincters, the muscles that act like valves.
And it's all controlled by the nervous system, right?
Yeah.
A mix of automatic and, well, voluntary control.
Exactly. It's not just one signal. It's constant communication. The sources break it down into two main phases. First up is the storage phase.
Okay, holding it in.
Right. The main bladder muscle, the detrusor, is relaxed. It's stretchy, making space for the urine as it fills up.
While the exits are closed.
Yep. The internal sphincter, which is involuntary muscle, and the external sphincter, the one an animal has some conscious control over, are both tightly contracted, shutting the doors.
So, bladder filling calmly, door shut tight. Makes sense.
Then, when it's time to go, things switch to the voiding phase.
Showtime.
Now the detrusor muscle, the bladder wall, gets the signal to contract. Squeeze hard. And this involves different nerves.
And
Critically, at the same time, the bladder squeezes. Both those sphincters, internal and external, have to relax. Open the doors wide.
Bladder pushes, doors open. Sounds simple laid out like that.
Deceptively simple, because it relies on really precise timing and signals between the brain, spinal cord, nerves, and muscles.
And that perfect timing, that coordination, that's where functional retention comes in. A breakdown in that symphony.
That's the crux of it, yeah. Something in that coordination goes wrong.
Okay, so if that's the normal process, where do the functional problems actually start? The sources seem to break it down into two main camps.
That's right. It basically boils down to either the bladder muscle isn't squeezing properly, or the doors, the urethral sphincters aren't opening properly when they should.
Let's take the first one. The bladder not squeezing. What's that called again?
The guide calls it failure of bladder contraction, or sometimes detrusor atony or hypocontractility. Essentially, the bladder muscle is weak or just can't contract effectively enough to push the urine out.
What makes the muscle fail like that? Is it just old age or damage?
The sources list a few causes, but the most common acquired cause, and this is really key from the guide, is prolonged overdistension.
Overdistension, so being too full for too long.
Exactly. Say there was a blockage before, maybe a stone, and it wasn't relieved quickly. The bladder gets stretched, really severely stretched, and the muscle fibers actually get damaged. They lose their ability to snap back and contract properly.
Like stretching a rubber band too far, it just loses its elasticity.
That's a good analogy. Another major cause is nerve damage, specifically, damage to the nerves that tell the bladder muscle to contract. The sources call these a lower motor neuron, LMN, lesions.
LMN. So problems lower down in the spinal cord or the nerves going directly to the bladder.
Precisely. If those nerves, like the pelvic nerve, are damaged, the squeeze signal just doesn't get through properly, or maybe not at all.
What would that look like in an animal? How would you know it's LMN?
Well, the source describes a typical presentation. You'd feel a large bladder, but it feels kind of flaccid, really easy to express manually. Often you'll also see decreased anal tone, maybe a weak tail-base reflex, that perineal reflex they mentioned.
And the animal might not even seem to be trying to pee.
Often, yeah, because that urge or the signal to contract isn't there. Examples the guide gives are things like cauda equina syndrome, which affects the nerves at the very end of the spinal cord, or maybe direct trauma to that sacral area.
Okay. Any other causes for the bladder muscle failing?
The sources mention primary detrusor atony, but say it's rare, and basically they don't know the cause idiopathic. And then, yeah, certain drugs can have the side effect of inhibiting bladder contraction. Things like anticholinergics, for example.
Got it. So that covers the bladder not squeezing. What about the other side? The sphincter's not opening.
Right, that's inappropriate urethral outlet resistance, sometimes called functional urethral obstruction. Here, the bladder might actually be trying to squeeze, maybe even squeezing hard.
But the exit ramp is closed.
Yeah.
The sphincters are clamped shut.
Exactly. They fail to relax, or sometimes they even paradoxically contract more when the bladder squeezes.
Okay, and this is where the source says it gets really interesting, right, with that specific coordination issue.
Yes. This is reflex dysynergia, or detrusor urethral dysynergia. It's like a primary timing glitch between the bladder contracting and the sphincters relaxing. It's not always due to obvious nerve damage. Sometimes it's idiopathic.
So the bladder yells go, and the sphincters yell stop simultaneously.
Pretty much. The bladder contracts, but the sphincters, especially that external one, either don't relax or they actually tighten up.
Wow. How does that typically look? The source gives a specific picture, doesn't it?
It does. It often happens in middle-aged, large breed male dogs. You see the dog posture to urinate, really trying, and maybe a stream starts.
But then it just cuts off.
Yeah.
Or it turns into a dribble.
Exactly. Interrupted stream, straining, but very little urine comes out, leaving a lot behind.
Yeah.
And the bladder often feels really full and quite firm because it's actively contracting against that closed door.
That paints a clear picture. What else causes the sphincters to stay shut inappropriately?
Well, distinct from the LMN issues causing flaccidity, the guide talks about upper motor neuron, UMN lesions. This is damage higher up in the spinal cord, above the sacral segments that directly control the bladder reflex.
And UMN problems cause tightness, spasticity.
Right. Instead of losing tone, UMN damage often leads to exaggerated reflexes and increased muscle tone. So the sphincters become hypertonic or spastic, making them resistant to opening.
How would that feel different on examination?
The bladder would likely still be distended, but the source says it often feels very firm and is difficult or impossible to express manually because those sphincters are so tight. But importantly, the anal tone and perineal reflex might be normal or even increased, which helps differentiate it from the LMN scenario.
And what kind of things cause UMN lesions affecting urination?
Things like slipped discs, IVDDs, spinal injuries higher up, tumors pressing on the cord, certain inflammatory brain or spinal cord diseases.
Okay. Are there non-nerve-related causes for tight sphincters too?
Yes, the source mentions a couple. Severe stress or anxiety can apparently cause a temporary situational functional obstruction. They also list certain electrolyte imbalances like high potassium or endocrine issues like Addison's disease as potential contributors.
And medications again?
Yep, certain drugs can increase urethral sphincter tone, specifically alpha-adrenergic agonists, which are sometimes found in decongestants or even some incontinence medications.
And the source mentions you can sometimes get a mix of problems.
Correct. Mixed dysfunction. You might have a bit of bladder weakness and some sphincter resistance happening at the same time. The guide notes this can sometimes happen as a secondary thing, maybe after a long period of obstruction that's weakened the bladder muscle over time.
Okay, so I've got the different ways the system can fail. If an animal has one of these functional issues, what signs might you actually see? The sources say it can mimic a mechanical blockage pretty closely.
Oh, absolutely. The signs that would make you worry are often the same. The guide lists straining to urinate, posturing, pushing, looking uncomfortable. That's stranguria.
Or going really often, but just passing tiny amounts.
Right. Frequent attempts with little result, polyuria, or just dribbling urine. A key thing is incomplete voiding.
That weak or interrupted stream you mentioned.
Yeah, the stream starts and stops or it's just drops, and you know they haven't emptied properly because the bladder still feels full afterwards. This often leads to obvious abdominal discomfort or pain.
And you mentioned emergency signs earlier.
Critically important, yes. The sources really stress this. If the retention is bad and goes on too long, the animal can become systemically ill. Signs like lethargy, not eating, and maybe vomiting.
Because the toxins are building up.
Exactly. It's called uremia. waste products that should be leaving in the urine back up into the blood because the kidneys can't filter properly against the back pressure. This causes postrenal azotemia, and the source is clear. This is an emergency.
Definitely sounds like it. What about leaking urine?
Yes, that can happen too, but it's deceptive. It's called overflow incontinence. The bladder gets so incredibly full that the pressure inside physically overcomes the sphincter resistance, and urine just sort of leaks out passively. It's not controlled urination at all.
So leaking isn't always a sign of relief. It could be a sign of severe backup.
Correct. And then on exam, the vet will almost certainly feel that distended bladder. How firm it feels can give clues, like we discussed flaccid in LMN, maybe firm in UMN or dyssynergia, and a thorough neurological exam is vital too.
Okay, so the signs look alarming, maybe like a blockage, but it's functional. How do vets tell the difference? You said it's a diagnosis of exclusion.
Right, and the absolute #1 emergency priority step, according to the sources, is ruling out that mechanical obstruction. You have to know if there's a physical blockage first.
And the key tool for that, the essential step.
Urinary catheterization. The guide highlights this as absolutely crucial.
How does that help differentiate?
It's often very clear. If there's a stone or a stricture or a tumor physically blocking the urethra, the catheter will hit a dead end. You'll feel firm resistance and you can't advance it into the bladder.
But if it's functional retention?
The sources say the catheter usually passes easily, with little or no resistance, right into the bladder, and then you can empty it. That simple procedure is often the biggest clue that you're dealing with a functional problem, not a physical one.
Okay, so catheter passes easily rule out mechanical. What next? What other tests did the sources mention to figure out the why behind the functional issue?
Well, after that initial relief, it's about digging deeper, getting a really detailed history from the owner, doing a full physical and neurological exam, including things like a rectal exam to feel the urethra, checking those anal reflexes we talked about.
Observing them try to urinate?
Definitely. Watching the pattern of urination or attempted urination can give big clues. Then basic lab work. Urinalysis and urine culture are essential. UTIs are super common as a secondary issue when urine sits around.
Makes sense. What about looking inside? Imaging.
Imaging plays a big role, according to the sources. Plain x-rays, radiographs can spot certain types of stones or maybe show spinal abnormalities. Ultrasound is great for looking at the bladder wall thickness, checking for sediment or masses, visualizing the start of the urethra, and importantly, checking the kidneys for swelling from back pressure, hydronephrosis.
Any more advanced imaging?
Yes, sometimes contrast studies are needed. That involves injecting dye via a catheter to outline the bladder and urethra on x-rays, which can show subtle blockages, urethral spasms, or bladder shape issues. And cystoscopy, using a tiny camera to look directly inside the urethra and bladder, can be very informative.
Wow, quite a workup. Are there even more specialized tests?
The sources do mention specialized urodynamic testing, things like systometrography, which measures bladder pressure as it fills, and urethral pressure profilometry, which measures pressures along the urethra.
Sounds definitive.
They can be, yeah. They directly measure the function and coordination. But the guide notes these tests require specific equipment and expertise, so they're usually done at referral centers or universities, not typically in general practice.
Okay, so diagnosis is a rule-out blockage first, emergency. Then use history, exam, basic tests, and imaging to pinpoint the likely functional cause, with urodynamics as a specialized option. Once it is confirmed as functional, what do the sources say about treatment?
Treatment really has a few goals. First, restore urine flow safely. Second, address the underlying cause if possible. And third, prevent complications like UTIs and kidney damage. The sources stress it's often a multimodal approach, combining different things.
What's the very first step in managing it, especially if it's an emergency situation?
After confirming it's not mechanical, the absolute immediate priority is decompressing the bladder. Get that urine out to relieve the pressure, usually via that urinary catheter.
Leave the catheter in.
Sometimes, yes. An indwelling catheter might be placed for a short period to keep the bladder empty while starting other treatments or figuring things out. Or, if catheterization is tricky for some reason, cystocentesis, draining with a needle, might be used carefully.
And dealing with those systemic effects, the toxins.
Crucial. Addressing metabolic consequences is key. That usually means IV fluids to rehydrate and help flush out toxins, correct the azotemia. And if there are serious electrolyte problems, like dangerously high potassium, hyperkalemia, the sources mention specific emergency treatments like insulin dextrose or calcium gluconate to protect the heart.
And treating any infection found.
Absolutely. If a UTI is present or suspected, starting appropriate antibiotics, ideally based on culture results, is part of that initial stabilization.
Okay, crisis managed, bladder empty. What about longer-term medical management?
This is where the pharmacology comes in, and it can get complex. The goal is usually to either help the bladder contract better or help the urethra relax better.
Using drugs for that.
Yes, and the sources emphasize it often requires careful dose adjustments, sometimes trying different drugs, and frequently using combinations, especially for things like reflex dyssynergia.
So for the weak bladder that detrudes or atony, what drugs help it squeeze?
The main one mentioned is bethanechol, which is a cholinergic agonist. It stimulates the bladder muscle to contract.
But there was a big warning with that one.
A huge warning, yes. The guide is very clear. You must be 100% certain the urethra is clear, that there's no obstruction or significant resistance before giving bethanechol.
Why?
Because if you make the bladder squeeze hard against a closed door, you can worsen the retention, cause intense pain, and potentially even rupture the bladder. So patency first, then maybe bethanechol. Cisapride is also mentioned as having some effect.
Okay, super important point. What about drugs for the other problem, the tight sphincters?
Right, for increased urethral resistance, you need drugs that promote relaxation. For the internal, involuntary sphincter, the sources mention alpha-1 adrenergic antagonists. Examples are phenoxybenzamine, which takes a while to start working, or prazosin, which acts faster.
Side effects to watch for.
Yeah, they can cause low blood pressure or sometimes GI upset, so monitoring is needed.
And for the external sphincter, the voluntary muscle one.
For that, you need skeletal muscle relaxants. The sources list diazepam, Valium, although they include a specific caution about potential liver issues in cats. Dantrolene is another option that works directly on the muscle. Baclofen is mentioned too, but maybe used less often.
And you said combinations are common.
Very common, especially for that reflex dyssynergia where both sphincters might be involved. You might use an alpha blocker and a skeletal muscle relaxant together.
What if stress is thought to be the trigger?
Then treatment involves addressing the underlying anxiety. The sources suggest environmental modification, creating a safe, calm space for urination, and possibly using behavioral medications like trazodone, gabapentin, or SSRIs.
Makes sense. For animals needing long-term help, especially chronic cases, what about home care?
This is a big part of management for some. The sources discuss owners potentially needing to learn intermittent manual bladder expression, gently squeezing the bladder to help it empty several times a day.
Or even catheterization at home.
Yes, intermittent catheterization is sometimes taught to owners for chronic cases. It requires commitment and careful technique. Also crucial is ongoing monitoring for UTIs. Regular urinalysis and cultures are vital because incomplete emptying dramatically increases infection risk.
And skincare.
Good point. Preventing urine scalding on the skin around the back end is important if there's any dribbling. Using barrier creams like petroleum jelly and keeping bedding clean and dry helps.
Okay, that's a lot involved in management.
Yeah.
Based on these sources, what's the general outlook? The prognosis.
As you might expect, the sources say it really varies. It depends heavily on the underlying cause, how quickly it was addressed, and how much damage might have occurred.
When is the prognosis generally better?
It's often good for acute episodes that are relieved promptly, like if it was drug-induced and the drug is stopped, or if a temporary blockage was cleared before the bladder got severely overstretched.
And when is it more challenging, more guarded?
The sources describe a guarded prognosis for idiopathic reflex dyssynergia. These animals often need lifelong medication, maybe multiple drugs, and might always have some degree of incomplete emptying. Also guarded for chronic detrusor atony if that bladder muscle is badly damaged. Recovery can be slow, partial, or sometimes not happen at all.
And when is the outlook poor?
Unfortunately, the prognosis is considered poor if the cause is a severe, permanent neurological injury. Also, if the condition leads to chronic, severe, recurrent UTIs that damage the kidneys, or if significant kidney damage has already occurred due to the back pressure.
Given all this complexity, the diagnosis, the management, the variable prognosis, communication with the owner seems absolutely paramount. What key points do the sources highlight for client education?
Hugely important. The sources list several things vets need to convey. First and foremost, inability to urinate is an emergency. Get help immediately.
Emphasize that rule-out mechanical step.
Yes, explaining why that's the critical first step. Then, setting expectations. Management is often complex, may involve multiple medications with potential side effects that need monitoring.
And the owner's role.
Emphasizing that consistent home care, whether it's giving meds on time or doing bladder expression, is crucial. Strict compliance is needed to prevent
And
setbacks.
managing expectations about the long term.
Right. Owners need to understand that relapse or progression is possible, and it might require lifelong management. They need to be vigilant about monitoring for UTIs. The focus often shifts to maintaining a good quality of life.
Cost is probably a factor too.
Definitely. The sources mentioned discussing the potential costs involved diagnostics aren't cheap, and long-term medications add up.
And knowing when to seek more specialized help.
Yes, the idea of referral to a specialist, a neurologist, or internal medicine specialist should be brought up for complex or non-responsive cases, especially if those advanced urodynamic tests might shed light.
So wrapping this up, this deep dive really underscores that functional urinary retention isn't just a plumbing issue. It's way more complex.
Absolutely. It's about the body's intricate control system, that delicate dance between nerves and muscles going awry.
Which really brings home that critical message from the sources. If your animal can't pee, don't wait. It's an emergency. Getting that potential mechanical blockage ruled out immediately is step one.
It dictates everything that follows. You have to know if it's a physical block or a control system failure.
Thinking about how something we take for granted, like urination, relies on such incredibly precise coordination. Brain, nerves, muscles, sphincters, all firing in perfect sequence. And how things like nerve damage, muscle stretch, or even stress can disrupt it. It really makes you appreciate the body's complexity. What's one thing that really stands out to you after digging into this?